Head and neck cancer is classified according to the area where it occurs. These cancers may involve the nasal cavity, sinuses, nasopharynx, larynx, oral cavity, or salivary glands. Risk factors include smoking, excessive alcohol intake, HPV, age greater than 50, exposure to the sun, asbestos, industrial carcinogens, marijuana use, radiation therapy to the head and neck, and poor oral hygiene. The nurse should encourage good oral hygiene, educate on safe sex practices, and tobacco and alcohol cessation programs. Early symptoms of head and neck cancer include painless white or red patches in the mouth, lump in the throat, a sore throat that doesn't resolve with treatment, or change in the quality of voice. Late symptoms include unintentional weight loss, difficulty chewing, swallowing, moving the tongue or jaw, or difficulty breathing. On the left, you'll see an early stage of oral cancer, and this is often confused as a canker sore. And on the right, you'll see a more advanced stage of oral cancer. Diagnostic studies include a focused physical assessment, indirect pharyngoscopy or laryngoscopy, biopsy, CT scan, MRI, PET scan, and TNM staging. T stands for the size of the tumor, N stands for the number and location of involved lymph nodes, and M stands for metastasis. Cancer can be staged from 0 to 4. Stage 0 is often called in situ, and this means that the cancer is confined to the area where the cancer began. And stage 4 is the most advanced stage. Treatment depends on the location of the tumor, the TNM stage, the client's age and overall health, urgency of treatment, cosmetic and functional considerations, and the patient's choice. Surgery is typically the first line for head and neck cancer. Vocal cord stripping involves removing the outer layer of the tissue on the vocal cords. It's ideal for biopsy or carcinoma in situ, and speech is not affected. Laser surgery involves inserting an endoscope into the throat, and the tumor is vaporized or removed. A cordectomy involves removing part or all of the vocal cords. Partial removal may lead to hoarseness. Speech is no longer possible when both vocal cords are removed. A partial or total laryngectomy involves removing part or all of the larynx. A total laryngectomy will affect airflow and voice production. A pharyngectomy involves removing all or part of the throat. A tracheostomy is the creation of an alternate pathway for breathing by creating a stoma in the trachea. A lymph node removal involves removing a number of lymph nodes depending on the extent of the disease. There's a few options for neck dissection surgery. A radical neck dissection involves removing all of the tissue on the side of the neck, from the mandible to the clavicle, and this includes muscle, nerves, salivary glands, and major blood vessels. A modified radical neck dissection involves removing all lymph nodes. Less tissue is removed than a radical neck dissection. Nerves, muscles, and blood vessels may be spared. A selective neck dissection involves removing fewer lymph nodes. Muscles, nerves, and blood vessels may be saved. Reconstruction involves restoring structure and function of affected areas. Other treatment options include chemotherapy, targeted therapy, and radiation. Radiation can be delivered either through external beam or brachytherapy. Brachytherapy is concentrated or localized method of delivering radiation. Radioactive seeds are placed near or into the tumor, and the seeds emit continuous radiation. This image shows how extensive a radical neck dissection is. The image to the left shows external beam radiation to the head. You'll see that the client is immobilized, and this is to target the specific area and protect healthy tissue. To the right shows brachytherapy. Side effects of radiation include oral irritation, ulceration, and pain. The client should be instructed to use a soft toothbrush, use warm saltwater rinses, avoid spicy or acidic foods, and use numbing mouthwash. Skin over the radiated areas can become red and tender. The client can apply prescribed lotion. Another side effect of radiation includes fatigue. The client may do light exercise, use energy conservation, and ask for help when needed. The client diagnosed with head and neck cancer may have a G-tube placed prophylactically. A swallow study should be performed post-op. Aspiration precautions and oral suctioning should be at the bedside. The client should be monitored for feeding tolerance, as well as nausea, vomiting, and diarrhea. The client should consume a high-calorie, high-protein diet with thickened liquids. The client may participate in physical therapy as well as speech therapy. Communication may involve an electrolarynx as shown in the image. Other methods of communication could include writing materials, picture guides, and laptops. Post-op care includes airway management, such as semi-Fowler's position to decrease edema and limit tension on the sutures, humidification, and tracheostomy suctioning. The client's vital signs should be monitored. A nonverbal pain scale should be used if the client has loss of voice. Pressure dressings, packing, and drainage tubes may be present. The nurse should perform stoma and NG tube care, maintain adequate hydration, and address psychosocial issues related to body image changes. The client should be taught self-care activities in regards to trach care or have a referral for home care. Swimming is contraindicated and shower precautions are needed. The room humidity should be maintained and the client should avoid aerosols. The client should be instructed to call the provider if they develop a fever, redness at the stoma site, respiratory distress, or bleeding.